pleasure of having Dr. Christopher Graver as our keynote speaker today. Dr. Graver is the Chief of Neuropsychology at Madigan Army Medical Center in Tacoma, Washington, and is board certified in clinical neuropsychology. He completed his doctoral degree at the University of Oregon, a neuropsychology specialty internship at the Phoenix VA, and a postdoctoral fellowship in neuropsychology at the University of Michigan. Dr. Graver has worked at Madigan since 2008. He's also served as an expert witness in a number of criminal trials and court martials. He serves as a reviewer for several journals, including the Clinical Neuropsychologist. He's published peer-reviewed articles and book chapters, and has presented at conferences around the world on topics from traumatic brain injury to cognitive test development and functional somatic syndromes. Fun fact about Dr. Graver, he was once offered a job at the University of Kansas, and we are very happy that he turned that job down. So, please join me in welcoming Dr. Graver for our keynote address.
Thank you very much. I am very honored to be offered this opportunity to be here and to speak with all of you. During my training, I was at 3 different VAs. I was at one in Oregon. I spent a year at the VA in Phoenix, and I tell folks I was there before the whole waitlist controversy. That was not me, okay? And then I was at a VA when I was in Michigan as well. And I've spent all but 18 months of my career working with active duty military after I was actually got my license. So I really like taking care of the active duty military. I like taking care of veterans. It's been something that's been integrated from the beginning. And so what I want to talk about with you today is the total care of veterans. And I know this is a TBI symposium, but I think we often look at TBI as a catalyst for a lot of these things, but it shouldn't stop with TBI. So I want to make sure that we're addressing everything else that's going on with that soldier or that veteran that is beyond just initial TBI injury. And a lot of the things that I'm going to say are actually going to mirror what was already talked about by Dr. Wolf and Dr. Hart earlier. And that was not a conspiracy. We didn't plan that. It's just a fact of there are a lot of commonalities between what we see in our clinics and the way we're approaching these cases and a lot of what's in the science. So I actually think this would be a good chance to review some of the things they talked about earlier. And I also think I don't really want to repeat a lot of things they said, so I want to be sure that we're going to look at things under the surface. The TBI is the obvious thing. What else is going on? Just a disclosure, I don't have any financial interests in this. The Army isn't even paying for me to be here today. I took a day off to be here and things. And they want you to know that this is not their official position. Sometimes I think it should be, but that's just my opinion. So I'm going to skip a couple of slides here because this was already well covered, and I didn't really realize that it was going to be, but we don't need to re-talk about why this is important. You know why this is important. What I do want to talk about, though, is this misattribution of symptoms. We often look at these as correlations. These things go together, but we don't as much look at what causes what. And what I think is interesting is if you delve into the literature, you can actually see there are emerging studies that look at more causal relationships. So one of the things we know is independent risk factors for TBI include things like low cognition to begin with, low education, low SES, and we know comorbid psychiatric illness is one of those things. Having worked for a while and continuing on an independent contract with the state psychiatric hospital, I see this a lot. I get called in when chronic schizophrenic patients end up getting TBIs because of something in their behavior. They got paranoid, they get in a fight, they get assaulted, that sort of stuff happens. They're at increased risk. We also know that if people get hospitalized after a TBI, it's more likely that they were intoxicated or they were engaging in some sort of risky behavior to have gotten it versus some otherwise accident that had nothing to do with their behavior. What I also think is we go back to statements earlier about it's not just the brain that gets injured, it's the person that gets injured that makes a difference. And very interesting study looking at twins. These twins were studied, they were tested cognitively before they ever had brain injury. So they have prospective information. One of the twins had a TBI, the other one did not, okay? And this was specifically actually looking at concussions. And what they found is in those individuals that had a concussion and showed lower cognitive performance afterwards, the initial reaction might be, oh, that concussion caused their cognition to be worse. But if you looked at it compared to their pre-concussion baseline, and you looked at it compared to their twin, they actually had no change. They just tended to be of lower premorbid cognitive functioning, and they were the ones that were more likely to end up getting these TBIs. It's kind of interesting. We need to look at that. Now, that doesn't mean that we're ignoring the TBI that had no effect and forget about it. This was all long-standing. But what it means is they may have lower coping abilities to begin with. They have lower sort of cognitive resources to deal with the aftermath of it, and they're going to probably need more support in terms of their healing than somebody who has a high cognitive reserve, who can actually compensate on their own, who figure this out, or has a bunch of folks around them to offer that support. So we're going to talk about this TBI iceberg, and I'm going to go through each of these 5 points with you, and we'll discuss this further. The first thing I want to talk about is psychological illness. So post-concussion syndrome is something that actually sort of irritates me or gets under my skin just because the name. Post-concussion syndrome is generally not something that I would attribute directly to the concussion, although the concussion is what starts it. What we know about it is there are other things that go on. You have psychological shock. It can cause momentary confusion and amnesia. It may be actually separate from any kind of TBI that occurred. We know that PCS is non-specific and non-neurologic kinds of symptoms. Now, earlier it was talked about with the PTSD, there's a lot of overlap between PTSD and the PCS. And the reason is because a lot of these are non-neurologic things. They're not related to the TBI, but they're related to things that come afterwards. We also know that similar numbers of head trauma and extra head trauma patients, so non-head injured patients, will report these symptoms and meet criteria for PCS. So you don't have to have had a head trauma to have this. No less real, but you don't necessarily have to have had that. We know that PCS criteria can't correctly classify people with 3 months, and I'm going to get back to that retrospective diagnostic issue later. There's a large overlap with psychological disorders and normal stress reactions. I don't know, being out here, how many of you folks will remember this, but about 25 years ago, there was a really big earthquake in San Francisco. Actually caused freeway overpasses to collapse, burst gas lines, caused buildings to catch fire and then collapse. It was a really big thing up there. And what they looked at afterwards in one study was they wanted to look at things like these common PCS symptoms. How many people had headaches? How many people had concentration problems? Were complaining of dizziness? Things like that. These were uninjured people. As far as we know, they did not have a head injury. They didn't have other injuries. This was just a general survey of folks. Just indicate base rate. Are you having these symptoms? And like 70% of the people said, I'm having trouble concentrating in the aftermath of this. Yes, you went through a stressful time. Your life was perhaps in jeopardy. And even if there was no actual injury, the level of stress is causing these problems. And so they're no less forgetful, no less difficulty concentrating, reading, and doing daily activities, but it didn't necessarily have to be the TBI that did it. And then the last thing is we know that subjective complaints are more related to emotional kinds of reactions to stresses than they are to any kind of physiologic findings when we're seeing PCS cluster. All right, so individual resilience plays a role. If they have low resilience to begin with, they're more likely to have ongoing symptoms afterwards. We also know that pre-existing psychological adjustment will play a role, and we know that current psychological symptoms will play a role. A lot of times these are not as sterile as you would think. You don't just get a head injury and all you have is a head injury and nothing else happened. There is some sort of event that had to be traumatic enough to cause an injury to the brain. You have to think that something else probably happened as well. Sometimes it's obvious. You get in a car crash or you're around an IED, you take shrapnel injuries, the car rolls over, you've got fractured ribs, whatever it is. There's other injuries that go along with it. So we know that that will go along with this. It's rarely that you get somebody who just had a hit to the head and there's nothing else that happened. And we know psychosocial support is a big deal. And if you think about soldiers being downrange, yeah, I mean, in military is family, but it's not quite the same as having your own family around. And a lot of times, if they have to get medevac, we try to put them into a place that's close by the family. We know that removing them from family is actually not a great thing, And if they're going to have to be in prolonged treatment, let's put them someplace closer to their family. Whether that's a current spouse, or maybe it's parents, or whatever it is. But they need that level of psychosocial support, and not all of them have it. And sometimes when they're downrange, they're already having family problems. There's divorce issues, there's infidelity, there's financial problems, because the private first class who's heading down there, and they've got a wife that they just married before they left, and who knows what that wife's doing with the money while they're downrange. They're getting stressed. We don't really have a lot of money. You're spending my combat pay. I'm not even back. You run into these problems, and you can't really deal with that effectively when you're that far away. And then ongoing litigation, disability compensation. That's not to say this is a bad thing and you shouldn't do it, but the longer this draws out, the more stressful it is. This is a stressful process. I mean, you folks probably know that as well, but taking it from the client side, there's a lot of uncertainties with that, especially the longer it draws out, and when am I going to get a resolution to this? And appeals and things like that come up, it's just, you gotta appreciate that's causing a lot more stress on them. And again, not saying that's not appropriate, but just appreciating that that's adding up as time goes on. So what's underlying this? I mean, you have these somatic symptoms that people are experiencing. They have the TBI, they have all this neurologic cascade of problems that are going on. Some of the symptoms, though, are common and normal. They're happening in greater than 50% of people. And what happens is people start to think, I never had these problems before, which isn't accurate. But they'll think that. I never had this until this event. It's really easy to anchor things to an event. And then what happens is they start over-interpreting. Yeah, these are all new problems, and these must all be caused by this event. And then what happens is they get diagnosed with it. Well, I've got a TBI, and they start expecting to have certain symptoms, or they expect to behave in certain ways or to have certain problems. And that actually can make their somatic symptoms even worse. So what was started with this neurologic change, we are now making even worse. And I'm going to talk about some of the things that will make it worse. Sleep. Sleep is a big one. You've heard this before. I'm not the first person to mention this. Here's the thing is poor sleep will cause problems with attention. It will cause problems with frustration. You get more irritable, you get more depressed. We've all experienced this to some degree. But if you haven't had a TBI, you don't know the degree that folks are having this. It's not that these are things that nobody has ever experienced. It's just a much more significant problem. You then get somatic dysfunction. There is a very good link between stress and depression and other psychological changes and immune system functioning, cardiovascular functioning, blood pressure changes, and you actually see people that are more highly stressed and not effectively having treatment for those things. They have many more doctor visits, hospital visits. There's actually a study looking at even criminals, incarcerated individuals who, when they were able to have outlets for the emotional stresses that were going on, they had much less infirmary visits. So we know there's a real physiologic change, that this stress cycle is just continuing on. And so the thing is you've got this little piece of TBI at the top that probably started that change. But you've got all these other themes that are coming up just because the sleep just keeps going and keeps going. So what happens when we get chronic partial sleep deprivation? This affects 70% of TBI patients. And so this is the majority. And what does this mean? This doesn't mean I didn't sleep for a night at all. This just means I'm sleeping 1 or 2 hours less than my body really needs. And it goes on and on and on. And the research says this is more damaging than missing a night of sleep here and there. You can make that up. This is hard to make up. In one study, 6 out of 7 different aspects of sleep that was looked at worsened after TBI. So it's not even like one thing has changed sleep. There's a bunch of different things that have changed sleep. Profound effects on cognition. I would say sleep is probably the number one thing that I'm seeing in my clinic as being a cause of cognitive changes. Get your sleep better and your cognition gets better. Maybe not totally back to baseline, but it gets better. And that gives people hope. There is a way to look at this. There's a way to treat this, and we can start you on that road to recovery. It's hard to focus. It's hard to be patient. It's hard to have frustration tolerance. So to even do some of these treatments and go through it and persist with it is really hard when you're sleep deprived. You've got to get that back to normal. The other thing is chronic deprivation is cumulative. And a lot of times in our veterans, we're not talking about missing a few nights of sleep. You're talking about they have a very high operation tempo to get ready to go, so they're not sleeping, there's a lot of stress going on, getting ready for that deployment. When they are downrange, they don't sleep well. I mean, that has just been a very consistent report. There is a lot of change to sleep patterns, even the cycles, the times that they're able to sleep, let alone length and quality. Then they come back, they have to reintegrate, they have to readjust, and their sleep's not back to normal. And by that point, you're talking 2 years of sleep disruption. Regardless of any kind of IED concussion they may have suffered downrange, this is already there, and this is already starting before they got the TBI. What that happens though is as this accumulates, it gives the impression that the TBI is worsening. So, in cases that I know discussed by previous speakers, if you do get some bleeding in the brain, you get some additional swelling, that can worsen it. But in the absence of those kinds of things, the TBI should be heading in the better direction. But it doesn't always do that. And this is what worries people. Why am I getting worse? I'm 6 months down the road and I'm not getting better. Well, sleep's a big reason why. You've accumulated 6 more months of sleep debt. All right, now medication overuse is another big thing that comes up. And I'm going to hit this just like Dr. Wolf did. Cognitive side effects. What are some of the most common medications folks are getting? Narcotics. Because usually there is some other injury that happens, but I certainly have seen physician's assistants downrange. I have a headache, take some ibuprofen. It doesn't get better with the ibuprofen by day 1, here's some Percocet. And then you start that cycle. Muscle relaxers. Right? You get that neck pain, you get that back pain, here's a muscle relaxer, that can do it. Anti-anxiety medications. You just got hit by an IED, your life was in danger, and you're having a lot of anxiety, you're having trouble sleeping. Here's a hypnotic, this will help you get to sleep. And then sleep medication, so Ambien and things like that. We see these very commonly. It's to treat the initial symptoms, but the problem is if you keep them going, you have those side effects that are actually detrimental. So the effects are better than the side effects acutely, but not long-term. So, rebound headaches. This is something that is really common in headache disorder clinics, okay? Rebound headaches. And essentially what this is as you take medications and then your body has like a mini withdrawal from them, you get the headache. So caffeine actually causes constriction of blood vessels in the brain. And that constriction is not necessarily a bad thing, but when that caffeine wears off, those blood vessels will dilate and maybe even dilate bigger than they were before, and that can be one of the causes of the headaches. But we also know analgesics, including narcotic medications, is also a big offender. So, I can guarantee you that soldiers use caffeine like nothing else, especially downrange, to stay awake. I can't tell you how many folks even come to my clinic, maybe 2 years post-injury, and they've got their Red Bull start off. An hour later, I need a break from testing. I'm going to get my Monster Energy drink, and I'm continuing with that. And at some point, it's like step away from the energy drinks. It's going to be okay. But that's where they're coming from, and that goes back to the sleep. Why are they doing the caffeine? Because they're sleep deprived. So now they're trying to make up with the caffeine. They have rebound headaches. The headaches interfere with sleep, and now we have this even bigger cycle that's going on. This is even worse and more. Interesting study. He was questioning whether this idea of post-traumatic headache, like long-term chronic, was even a phenomenon associated with that initial hit. They looked at individuals that were taking either caffeine-related medications or analgesic medications, and they were randomly selected to stop all medications. You have to stop it for 6 months, or you can take them intermittently as needed for headaches. So not daily basis, but as needed. Maybe you're taking 2 or 3 times a week or something, maybe even less, maybe even once every couple weeks or whatever it was. And at the end of the 6 weeks, even though that group that stopped the medication got worse initially, they had the rebound, they're having worse headaches, more frequent headaches, by 6 months, completely headache-free. And the group that continued to use intermittent medications, it relieved their headache in the moments, but they were still having it in 6 months. So this goes back to, again, what Dr. Wolf is saying. One of the first steps is get them off the medications and let's see where things go. And you can understand as a soldier, if you're looking at this, my head hurts and they gave me medication, the doc said it's okay, take this, and I take it, my headache gets better. They a lot of times don't want to be on those medications. They try to wean themselves off, but they don't understand the headaches are going to be worse for a little while. And you're just going to have to persist with that, and you're going to have to stick with it to ultimately reach the goal of being headache-free. That's not told to them, they don't understand it, so as soon as they try to wean off the narcotic or wean off the caffeine, and hey, a week goes by and I'm still having headaches. this obviously isn't working, let me go back and put the medication in. So they have to understand that to begin with. One of the medications that's used as prophylactic treatment for headaches is topiramate. The problem is the brand name is Topamax, and we affectionately refer to it as Dopamax because it makes people feel dopey. Deterioration of attention, verbal memory, verbal reasoning with this medication. So while it's prophylactically helpful for the headaches, it can cause some cognitive problems. Sleep, benzodiazepines, huge cognitive effects. So just to give you a context, effect sizes of -0.8 or bigger would be a large effect size. So we're talking about anywhere from a moderate to a very large effect size on different areas of cognition and use. So I would not take these lightly in terms of the cognitive effects they can have. And then finally, the muscle tension, the muscle relaxers. So Flexeril, that's a big one, cyclobenzaprine. It's prescribed quite a bit. It can make you confused, can make you amnesic, and you see folks on this. I've seen folks that I don't actually think they had a concussion. They just had like a neck strain from an accident. They get put on Flexeril to treat that, and like a day or two later, they're coming to their doc saying, I can't think straight, I'm forgetting things, I'm confused, and oh, by the way, I hit my head 2 days ago, and the immediate assumption is TBI. Maybe, I don't know, I wasn't there. But from the details I can gather, I mean, the emergency department didn't see anything. They're not diagnosing it. The diagnosis is coming up later, and I'm suspicious that the medication may have started that, or if they did suffer a TBI, it was pretty mild, it wasn't picked up by the EP, and this has just made it worse because the brain was already susceptible to that with the injury, and then they're going to be more sensitive to this. Antihistamines, Dr. Wolf mentioned that that's anticholinergic properties, so consider this slide, which again, not planned ahead of time, but we're on the same page here. This is showing you non-users versus users of anticholinergic medications, and the first two, the higher scores mean worse functioning, so worse reaction time, worse attention, and then the other ones, lower scores indicate worse functioning. And what you can see is in every case, anticholinergic medications are causing changes or differences from non-users. Some of them bigger than others. Certainly speech fluency and reaction time seem to be some of the biggest differences versus spatial. But they do cause changes, so we have to think about the medications. What are they doing, especially to a brain that's been compromised in a TBI? Now, expectation about recovery is a really big thing. So, medication, sleep, or physiologic based, these are psychologically based. And what we know is the expectations that people have about recovery will actually influence their recovery, independent of other sort of physiologic changes. So we want to get them on the right page. We don't want to, blow sunshine at them and say, hey, it's all going to be great, you're never going to have any residual problems, we can forget about this. But we want to give them a realistically positive outlook for what's going to happen and not get them overly worried or overly scared about things that may not or are unlikely to happen. So what we know is patients underestimate the symptoms prior to the injury. Okay, and I talked about this earlier. So following injury, people tend to attribute all symptoms to that event. There was a study done looking at this idea, this diagnosis thread. Like if you're told that you have an injury and you should be worried about it, what happens? So they took a study of concussion patients. So all these folks had concussions. They randomly assigned them to a group that was said, hey, come be in a cognitive study. We just want to check things out. So that's a neutral group. Just come be in our study. And the other group was told, hey, you had a concussion. You're in this study because we want to check and see what happens to concussion and see if it affects your memory and other things. And so in this group, it's told, your concussion can have lasting effects. Look what happened. Control, so non-TBI groups, and the group that was in that neutral condition, they're just in a study. Not mentioning the concussion as the target or that this could have lasting symptoms. They didn't differ. But the threat group actually had more subjective symptoms than the other group. And in one study, there's no differences on cognitive tests. So importance of looking objectively, not just taking their subjective report of it. But also, one study actually showed, this Gunstad and Sur in 2000, actually showed that if they looked across a battery of cognitive tests, in this neutral group that had concussions but not told about it, about 12% of them had an impaired test score. Okay, so 12% had an impaired test score. In the group that was in that diagnostic thread, they actually found 46% of them had a low score. Almost 4 times as many, even though they had the same histories, and they looked at other factors. There was no difference in anxiety and depression ratings. There was no difference in sort of motivation and effort or validity of test results. Simply by being in this group with that made as the centerpiece, they're doing worse. So again, caution about don't go too far. We don't want to cause panic about these things. We want to be realistic about these things. So if I can give you a slide that illustrates how much people underestimate their pre-injury, the first set of bars is going to give you a sense of what does the average healthy person report about these different symptoms. And then the second set is when individuals have had a TBI, they're asked to estimate their pre-existing problems. So like, for example, the first question is how often did you lose your keys? Or how often do you lose your keys? And what you see is in normal individuals, about 40% of people have lost their keys at some point. I actually suspect that's an underestimate. I mean, we've all lost our keys at some point, okay? But still, I mean, 40%. And then when people with TBI are said, all right, before your TBI, how often did you lose your keys? Or how many of you have lost your keys? It's less than 25% are saying they lost their keys. An underestimate of how often they were doing things. And you can see that for all of these. And I was actually really impressed with the last one, blurry vision. Nobody in that TBI group said they ever had blurry vision before the TBI. And yet, normals, it's approaching 10% who said at some point I have my vision blurred. So that even that symptom does happen in normal individuals to some degree. Not very often, most of us don't have that happening, but it does happen sometimes. And yet there's complete denial that ever happened before. All right, so what do we know about expectations? Subjects in one study were given vignettes about concussion, and everything was the same except in one set they were told the concussion happened in a car accident, and in one set they were told the concussion happened in a sports injury. And what she found is individuals rated the outcomes of the car accident as being more significant or more negative than those in sports injury. Nothing else about the vignette differed. So their expectation that a car accident carries more significant injury just trumped any actual factual data that was in it. So that expectation carries them. Here's another study that looked at patients in the emergency department and 3 months post. And what's interesting is that if they had a belief in serious negative outcomes of concussion or ongoing consequences, they're more likely to be diagnosed with PCS in 3 months. This was independent of the severity of injury. It's independent of other trauma symptoms that were going on. And it was independent of anxiety and depression symptoms that were going on. So these will play a role, but once those are factored in, if you believe you're going to continue to have symptoms or you believe that this will be permanent, then you tend to actually then develop some symptoms. And I don't say that to say we shouldn't believe that they're having the symptoms. They are. But we just need to look to where are these symptoms coming from. Finally, depressed patients. If you look at depressed patients, they expect more symptoms than healthy athletes or healthy adults, and they expect more disabling symptoms from concussion. So not just more in terms of numeric, but they expect them to be more disabling. So depression, we know, has a very negative filter. Depressed people see things as being much more negative. They can't help it. That's part of the disorder. And they do that for this too. It was mentioned earlier just how many folks after TBI develop depression. So they actually may be seeing things as worse than they are. So we need to go both ways. You know, we want to meet them where they are and what they're seeing, but we always want to appreciate too, what is the objective information indicating, and how much is that discrepant from the subjective? Because there may be a room for intervention there to help them have a more balanced view of things. And then finally, TBI knowledge. This is one that's, again, maybe somewhat shocking, but I think is important. First of all, patient reporting is inaccurate. We hate to hear that. And a lot of people will base their decisions and their diagnostics on patient reporting only. We really need to have objective testing. So here's a study that was done in the VA. They're looking at they're looking at a lot of things about concussion. And essentially what they did was they had They caught people as they got their concussions. They checked them out. Actually, it wasn't even just concussion. Any TBI that happened, they caught them in the emergency department, and they asked them questions as long as they weren't comatose or anything like that. But they asked them questions and said, all right, how did you get your injury? And let's talk about all these potential symptoms you may have had. Did you have amnesia? Did you have dizziness, balance problems? Did you have light sensitivity? Did you have headaches? They went through all of that. And 6 months later, they came back and they asked those same patients, they said, all right, think back 6 months ago when you had this injury and you were sitting there in the emergency department where we were questioning you. I want you to answer these questions again. Retrospectively, think back to how you were feeling at that time and answer these questions. And patients were incredibly inaccurate. So for the mechanism of injury alone, for those that said they got their head injury by a car accident, 36% of them changed their answer about how they got injured at time 2, okay? For falls, it was 48% inconsistent, and for blunt trauma, it was 43% inconsistent. Now, what does that mean? That means they changed their answer from time 1 to 2, just about how they got the injury. And if you think about it, if they're that inaccurate about how they got their brain injury, how accurate are they going to be about the other symptoms? Okay? Now, if you think about it and think about everything that's been talked about, we know when people get injured right away, they feel off. They feel amnesic, they feel disoriented, they're confused, they're maybe seeing stars. There's a lot of things. Mr. Washington talked about some of the things he was experiencing with that game. And going back out on the field and not really tracking the plays and having to re-ask questions, and then later not even remembering when watching the film. Very common to have that sort of thing happen. So if you think about it, if they are having a disruption in fundamental brain activity at the time of the injury, why are we going to rely on them to be accurate informants about this? That doesn't make any sense. They are confused. Their brain is not working correctly. They are going to be forgetful. We need to rely on actual information from the time of the event. A lot of times if I see folks after the event, I go right back to their emergency department record or even EMS records on the scene. I want to see what's happening. Not because I don't think the patients are trying to tell me accurate information, but they're often incapable because they were unconscious, they're confused or whatever. So I need to know what's going on. Here's some other things I think were interesting. Amnesia, whether they had it, post-traumatic amnesia or not, 32% inconsistent. Light sensitivity, 39% inconsistent. And balance problems, 48% inconsistent. So they can't accurately report their symptoms in a lot of cases. There's not good reliability across time. So you need to check those records and we need to do it. It's important on us as a provider to document and assess it accurately. And then I think it's important as as advocates, to get those records because they may be telling you things that are more severe than is actually the case, but they actually may be telling you things that are less severe than is actually the case. So you need to check that because there may be things going on. And one of the questions asked earlier is about that awareness and that insight and how much are they reporting. And we know that individuals with the more severe brain injuries are less aware. They report less symptoms. I'm going to back up just if I can really quick here. Right here. I think this carrot analogy, or my iceberg analogy, is really good. If you're thinking of the carrot as sort of the things that are hidden underneath, and you think of the green sprout on top as the TBI, well, in that first case, the severe TBI is what you see. It is so clear what's going on there from the outside. But from them on the inside, they see this little tiny carrot. There's really not much wrong with you, not much has changed. But if you take the mild TBI folks, we're going, are you really brain injured? I don't really see anything too obvious. And to them, they're noticing all of these internal things because at least to some degree with the more mild injury, they're aware of these things. They know something isn't right. They know something's changed. They actually can appreciate when somebody else tells them, you weren't really acting right. Or, we had this conversation yesterday. And there's people they can trust and they realize that, wait, this isn't normal. I shouldn't be forgetting this stuff. Or how come I don't even remember going in the ambulance to the emergency department? They realize that. The severe TBI people don't realize that. So you're going to get a fundamental difference in what you're going to get reported depending on what that is. So get the records. All right, now, it's not all of the patients though, it's on us too. There's a huge problem with deficient TBI knowledge, huge. Although the assumption is, well, the doc said this, so this is what the doc put in there. And I hate to, and I don't want to put our profession down, but I think we have to be realistic about what we do know and what we don't know. Looking at TBI knowledge, it is poor across a lot of groups. It's poor for veterans on what they understand. It's poor in minority groups. It's poor in physicians and nurses. There are many, many studies that have been done that show that our knowledge is poor. In the TBI knowledge test that was given to professionals, 51% correct overall. What kind of grade do you get for 51%? Right? Nobody here is saying, that's what I want in my final exam. And yet that's what we're doing. Amnesia and recovery were the most common misconceptions. Okay? Physician knowledge in one study was equal to the lay public's knowledge of TBI, in general physician knowledge. They don't know anything more, and yet you're like, hey, you know, your primary care doc said this. Okay. I've seen it happen both ways, where I've seen where it's been missed, and I see where it's been diagnosed and it's ruined careers. Individuals that are aviators have a special flight status in the military. They have to have special physicals to get on flight status, and if they ever get a hit to the head, they have a special protocol they have to go through to get a waiver to get back on it. Neuropsychological testing is part of that. They have to see a neurologist, they have to get a brain scan, and they have an automatic 30-day grounding, even if it's a mild TBI, automatic 30-day grounding. And I've seen individuals that they see a PA or they see a nurse, case manager, for this initial screening, and they may actually not have had a TBI, even though they had a hit to the head, which is my last point. Head injury does not equal brain injury. There is some level of protection in there. And what happens is they'll get diagnosed with a TBI based on inappropriate knowledge of symptom reporting or the injury characteristics, and then there's nothing we can do. 30 days off of flight, and I have a really unfortunate case that's ongoing right now. It's not resolved, but the injury occurred in July. And this person, it was one of those cases where, you know, the guy was in an F-250, got hit by a Prius. Okay, no airbags, no nothing like that. He was perfect. He did not lose consciousness. He had no amnesia. He actually provided a very coherent story of what happened, because he said, I was carrying a sidearm in my car. I realized after the accident, they had called an ambulance. Somebody at the scene had called an ambulance. He was checking himself out. He said, I don't think I'm injured, but if they're calling an ambulance, maybe I should go get checked out, which, again, good thinking, because a lot of times if you're concussed, you're not doing that. You're combative with EMS, and you're out of it. He called a friend and said, you know, I think the ambulance is going to take me. Can you come get my sidearm? Because I can't take it to the hospital and I don't want to leave it in the car. So there's a lot of good thinking there. And then the friend actually said, I'll just take you. And, okay, so the friend took him. Emergency department checks him out. His only complaint is neck pain. They give him a muscle relaxer. The next day he comes to his physician's assistant and says, gosh, I'm really off. I'm not remembering things. I'm not thinking well. I'm confused. I'm disoriented. And the physician's assistant says, yeah, well, you just got in a car accident. You've got a TBI. And then grounds him. So the protocol starts. I see him, and when I evaluate him, he actually does pretty darn well on most everything. He says he's fine about everything. He does pretty darn well on most things, but there were a couple of tests, especially in terms of sustained attention and like processing speed, that were a bit off. And so that was interesting. I'm not ready to send you back to flight yet. I'm not going to clear you for this because you're still having some problems. But I start digging further and I find out his neck pain was ongoing, so he was having trouble sleeping, to the point that the PA said, I'm going to give you a benzodiazepine to help you sleep. Well, first of all, if your sleep's that disrupted, I expect that you're not going to focus and process things well. And then you started a benzodiazepine 2 days before you saw me. If I had known that, I probably wouldn't have even tested him. I would have said, we got to get this resolved. So they're trying to get him off of that. And the thing is 2 weeks later, I'm set to see him. He cancels the appointment because he says, gosh, I don't think I'm ready to come back. Which is really weird, because now we're sort of about 45 days post-injury. I would have expected him to be better and be fine. And he's saying, I'm not really back to myself. Okay, so we push off the exam. About 60 days later, he says, I'm ready to go. I think I'm fine. And we actually do something called a flight check. So we put him on a helicopter. He's got an instructor with him to make sure everything's safe. He goes on a check flight. He comes back, and I test him in the hangar immediately afterwards. I want to see what his functioning is like right after having done the test flight. And same thing. He does well almost everything. Problems with attention and processing speed, but now it's even worse than it was initially. Which is weird, because this concussion that I'm not even sure if he had, shouldn't be getting worse. But what's happened is He's trying to get back to flight. He's bummed that he's been off of it for so long, so now he's not reporting his sleep problems. But they're going on. He's now had 2 months of sleep debt accumulating. Not surprising. So we've got to intervene on the sleep. So we intervened on the sleep. That seems to be going better, and I'm now at this point just waiting for him to say, sleep's great, I'm ready to test again, and then we'll go again. So an unresolved issue, but one of those things where I hate to see it go in the other direction too. I want to take care of folks if they've got it, but I also want to appreciate all these other factors that might have happened. And if he had a concussion in that, maybe, and maybe that's what started his sleep problems. And maybe then the medications affected him more. So I do want to be careful, and I am glad we caught it. I don't want him in the air right now with this sort of stuff going on. But I wonder how much would have changed if we had told him, like, hey, you are going to have some problems, you are going to have some changes in sleep and things like that, but if you can hold off on the medications, or if you can take it short term and then let's get you off it, how much that might change. All right, so here was a study just last year. This was done in the Army. And the Army approved this, so I know they probably don't like me talking about it, but they approved me to present this. This was looking at concussion knowledge in the Army. And actually, it's all of TBI, but these particular questions are related to concussion. These were the 4 worst ones I pulled out of here. But here's the number of correct answers about delayed onset of symptoms. It's about 35% correct. Patients forgetting who they are. Now, severe TBI patients may lose some autobiographic knowledge, but concussion patients are not. Beyond that first initial confusion period, maybe that first 24 hours, they're going to know who they are, and they're going to know what's going on after that. Complete inactivity as a recovery piece. Patients should not have complete inactivity as a concussion recovery. They need to get back to activities. We're not putting them back in the game. We're not setting them off to do final exams. I'm not talking about that. But they do need to get back to a moderate level of activity. Multiple studies have shown this, even when they have randomly assigned people to complete rest or moderate activity people have less symptoms and get better quickly. It's just like if you pull a muscle. You don't stop using it altogether, but you don't try to run full speed on it either. You nurse it, you do some treatments, you stretch, you start doing some PT, you get back to it slowly, and that's the same thing we've got to do here. But you can see we've got a 60% incorrect answering about that, saying they should have complete complete rest, no stimulation, and that's not the way to go. And then the last one is the full recovery. I mean, most people are going to have full recovery, and I can tell you, I've had moderate to severe TBI patients who look, on testing, objective testing, nearly baseline level. Few small things that they need to compensate for, but they can do it, and with their compensatory strategies, they look pretty much normal. Now, that's not necessarily the norm, but I am saying it's possible that even with a severe TBI, you can get back to pretty darn good functioning. So we don't want to automatically assume that they're never going to get better. It just may take longer, it may take more interventions, it may take more work. But I was just appalled that we have this poor knowledge about it, and yet a lot of times a specialist like myself or a specialist like Dr. Wolf or Dr. Hart are not the first line people that are getting to them. You're getting other folks who are going to see them first, and then like where does that lead to? What kind of information are they getting if these folks don't even know about it to begin with? So the point of this is I don't want you to necessarily get TBI tunnel vision. So TBI starts this whole cascade of things, but don't put your eggs all in one basket. And I think if you're going to be a good advocate, you've got to consider these other things, because if you're saying this is all TBI, the standard treatments don't work. And then your client gets frustrated, and they get demoralized, and then they start developing more problems. And so we want to say, all right, what else is going on? What else do we need to be advocating for to get you all of the treatment that you need? So we need to advocate for all the needs. So I'm not saying we shouldn't pay attention to TBI, we absolutely should. It's very important, but we need to pay attention to the cascade that comes after that too, because we could be missing the total care of our patients. So, in sum, we've got to look below the surface for all the issues. Okay, not just what they tell you, and consider that reporting may be inaccurate. We need to ask about expectations for recovery. A lot of time, I always ask patients, what have you been told about recovery? And I would say probably about 60% of them have been told nothing. Or at least they don't remember being told nothing or anything because they're concussed, they're amnesic, and somebody tells them as they leave the emergency department, blah, 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 blah. They're not going to remember that later. I would say probably another 30% or so have been given misinformation about overly sort of dramatic or tragic outcomes, and this is going to be permanent and you're never going to get better, even in concussions. And probably only about 10% or so, again, an estimate on my part, that are actually given accurate information. Here's what we know, here's the treatment you need to do, and here's at least our reasonable prognosis for you getting better. And then I would say get objective records and go to specialists. So I'm going to put one last plug here as we finish up. A lot of times this is not understood by a lot of folks, including my physician colleagues, who I try to educate all the time about this. Clinical psychologists are not the same as neuropsychologists. Neuropsychologists have specialty training well above and beyond what clinical psychologists have in neuroanatomy, in neurologic outcomes and recovery, functional imaging, functional neuroanatomy. We understand the relationship between behavioral correlates and these underlying neurologic changes, so we can put together the whole picture. A lot of times that's not appreciated, and people will just go to a psychologist and say, here it is. And there was actually a case, I think it's in North Dakota, of a psychologist who had a board complaint against him because he was weighing in on TBI issues, saying he had no specialty to do such a thing. It was a VA case. And unfortunately, he was trying to pull away the TBI rating, saying, no, you actually did have a TBI. And it was, I think irresponsible to be that far after in a rating process in the VA and try to say you never had one. Especially when you don't have the expertise to go back. And even with my expertise, I try not to retrospectively second guess what happened. I really like to have, if the ED record says it's there, I'm going with that. They're the ones that were there on the ground at the time, they know best. So I would not try to do that. So keep in mind that you want to have a neuropsychologist evaluate somebody for the cognitive and other, not just a psychologist. And then also consider whether they're board certified. So I'm board certified, Dr. Hart's board certified. With the concussion settlement, it's mandated that the baseline assessments and subsequent assessments are by board certified neuropsychologists. That's for a reason, because anybody can call themselves a neuropsychologist. Not everybody is trained as one. And so the board certification is the only thing that's necessarily protected. The sort of title of neuropsychologist is not legally protected. So keep that in mind. Look for specialists to weigh in on this, because the general kind of population of providers is not going to know about this. And I think finally, if you do all those things, you're going to have better representation and we're going to have better care for those veterans. So I'm going to leave it at that, and certainly any questions you have, I'm happy to answer. Yes?
Does neurofeedback, neurobiofeedback help to objectify symptoms of TBI, PCS patients, and how effective or not that treatment?
Yeah, like neurofeedback or biofeedback isn't necessarily going to objectively document what's going on. Certainly an EEG might pick something up. I would say biofeedback can be a great adjunct treatment for it. It actually works well in headaches, and being a non-pharmacologic, non-side effect kind of thing. A lot of times we will send folks for biofeedback for their headaches. That's a great approach, but I wouldn't say for documenting those kinds of symptoms that are ongoing. Yes?
Do you have any sense of, those numbers were kind of horrifying in terms of the inaccuracy of the reporting, both as a patient and as an attorney and a daughter of an Alzheimer's patient? Any sense of what could be causing that inaccuracy? What could be done as a report taker when you're an attorney and you're getting facts from your client or witnesses or whatever to produce that inaccuracy?
Yeah, so I'm going to give you my opinion on that, so it's not research-based. But what I think from my experience is a lot of that misinformation comes from folks who are really trying to be good treatment providers and good advocates. And so it's hard, I think, to look at what the science says and then put that to the patient. So if the patient's telling you something, it's hard to say, no, this isn't what the science says. And it's hard to say, what you're experiencing. I think sometimes it's a hard balance, because you don't want to say it's not real. And I always try to tell patients, I totally believe what you're having. But to then try to attribute it to something other than TBI, sometimes I think they feel like, well, I'm not advocating for their needs, or I'm not helping them out if I try to look at other kinds of things. And so it's like the idea that, hey, if they have a brain injury and I diagnose it and I treat them with brain injuries, they're getting the services they need is, I think they're just trying to advocate. I think they're trying to come from a good place, but there has to be a balance between what is TBI and what else is going on with TBI. And that's where I think it comes into. So you can give them the factual knowledge, but in the moment they're emotionally connected to patients or clients or things like that. I just want to do everything I can for them. I think that's where that's coming from. And I try to educate as much as I can, which is why I always appreciate, when I come to places like this. I'm going to try to do it at the local level. And so we try to get that word out. And I think we've made pretty good progress. I've seen a lot of changes at our own facility. with our neurologists and other folks, even our primary care docs send to us a lot. They really trust us to look at these issues now. When I first started working there, in 2007, it wasn't that way.
You're not going to be happy if you miss your flight.
I won't. So,
Thank you.
very much.